more specifically, I'll be speaking on tracheal intubation and whether it's life-saving or life-threatening. Now, we know that tracheal intubation is one of the most commonly performed procedures in the ICU, and it is an essential part of resuscitation, and almost every resuscitation includes airway management, and tracheal intubation is probably one of the best forms of airway management. However, we take it for granted, and tracheal intubation is something we do reflexively, we do instinctively. If something happens, we don't worry too much about it, but we need to consider what happens with tracheal intubation in the ICU. Now, we often try and extrapolate the experience of anesthetists in the OT to the intensive care unit. But intubation in the ICU and intubation in the OT are vastly different. They're just poles apart. So in the OT, intubations are usually done by skilled anesthetists. They're always present. Generally you've got stable patients who are in good condition. That's why they're undergoing surgery, with the exception of a few sick patients or a few emergency operations. Mostly elective intubations. Of course, the patients are by and large prepared for surgery. And once in a while you have a mishap, once in a while you have a difficult problem. But otherwise it's largely everything is controlled, everything is stable, and conditions for intubation are optimum. You've got people to help you, you've got drugs, you've got skilled people, you've got all the equipment. Whereas in the ICU, it's completely chaotic. I mean, imagine the ICU at 3 in the morning and you've got a patient with a bad pneumonia who comes in. You've got the junior most resident on duty, there are no seniors around. You've called the anesthetist and he's busy in the operation theater doing something else. The skill levels are varied. You may or may not have an experienced person at intubation. Patients are very unstable often. They have very little physiological reserve, and you have very little time for preparing the patient to oxygenate the patient or do something well, and the environment is completely chaotic. Okay, you may not have people to help you. The people around may not be familiar with intubation. If they are familiar with intubation, you may not be the best person to intubate some patients. If you land up in trouble, you may or may not have people to come and take over and help you. So intubation in the ICU can be a potential problem. And we took it for granted many, many years ago, when in 1995, this was a sort of eye-opening study which came up from the US. And they looked at almost 300 intubations, and they found that there were incidents of difficult intubation in 8%. That's all right. I mean, it's high, but okay, so what? Esophageal intubation 8%, aspiration 4%, but 3% of patients died within 30 minutes of intubation. Now, if any anesthetist had 3% of his patients dying within 30% of intubation, he would not be an anesthetist for more than a year. He would be sacked immediately. But 3% of patients died within 30 minutes of intubation, and patients who were hypotensive were more likely to die after intubation than normotensive patients. So maybe something to do with the condition of the patient had something to do with it. These were patients who were accidentally extubated, so they self-extubated or something happened, and they had to be re-intubated. So this was again an emergency intubation. Hypotension, systolic BP less than 80 in 35% of patients. 22% of times they had to do multiple attempts to get the tube back in. The intubation was difficult in 14%. Hypoxia during intubation 14%. Esophageal intubation 14%. One cannot ventilate situation, cannot intubate, and death. So one patient out of 57, almost 2% dying just because you could not get the tube back in. And only 1/3 of patients had no complication. In other words, some complication was there in 2/3 of patients. So again, focusing on the fact that, things go wrong during intubation. Maybe not because of intubation, but during intubation, and maybe because of intubation, things do go wrong. And if you say, no, that was in the 90s and now we are much better off, these are two studies which have come recently in the last 5 years. And one is from France. They've done a lot of work on this. Severe hypoxia, saturation less than 80% in 26% of cases, and almost 20% of patients here. 2% cardiac arrest. Severe hypotension, 25%. Aspiration, almost 6%. Several patients, almost 12-15% getting multiple intubation, esophageal intubation happening. So again, the whole intubation seems to be pretty chaotic and prone to complications, some of them minor, some of them life-threatening. So severe hypoxia, severe hypotension, aspiration, deaths, obviously a problem. This is from a study which was published comparing the safety of etomidate versus ketamine for intubation. And this was a large study. Okay, there are almost 700 patients, 650 patients. But look over here. Difficult intubation in 10% of patients. Okay, change in SpO2, 0 to 6%. Cardiac arrest during intubation, 3% and 2%. So cardiac arrest occurring during intubation, difficult intubation, happens in a large number of events. Now why? Why do all these things seem to be happening? It never happens in the OT. And if I told someone that in the OT I was intubating and 2% of my patient had cardiac arrest, 25% the saturation went down to 80%, they would say, you don't know how to intubate, you don't know what you're doing. But this seems to be happening not infrequently in critical patients. Obviously, it's got something to do with the patient's condition. The other, and okay, you can say, okay, patient had pneumonia, patient had ARDS, patient had pulmonary edema, he was hypoxic. But also what is very important to understand is that the response to pre-oxygenation is not good. Okay, so normally when you pre-oxygenate, the PO2 rises. So in this study, in 34 stable controls with pre-oxygenation with the bag valve mask for 4 minutes, the PO2 increased from 80 to 400. So that was great. But in patients who are unstable and were being intubated in the ICU, the PO2 only increased from 64 to 86. So very little increase in the PO2. 40% had less than 5% change in baseline PO2, and only 15% patients reached a PO2 of 100. In other words, once patient is sick, you give them oxygen, the pre-oxygenation by the conventional ways, they don't have enough oxygen reserve, and if the patient is apneic, if the patient doesn't breathe, if you cannot intubate on time, then there's very little oxygen reserve for this patient, and he can then have severe hypoxia and other complications. It's not uncommon to see patients struggling, taking at least a couple of attempts to put the tube in, and if less than two or less attempts were made, then the incidence of hypoxia and severe hypoxia was there, but probably not all that high. But if 3 or more attempts were required, hypoxia, 70% of patients, severe hypoxia, 28% of patients, esophageal intubation, more than 50% of patients, cardiac arrest, 11%. So if you make 3 attempts or more in a sick ICU patient, you can expect 11% of patients in this study had cardiac arrest. Okay, bradycardia and 18.5. So I mean, it's fairly dramatic sort of complications as the duration of intubation and the number of attempts keep going up and up. And in this study, they suggested you should limit the number of intubation attempts to 2, and then call someone else to do the intubation. Esophageal intubation does happen, and again, sometimes we try to take it for granted. Chalo tube andar piche gaya, nikal do, wapas dal do, do it again. But see what happens. If you have one episode of esophageal intubation, 50% of patients had hypoxia. The risk of hypoxia increases 11-fold, and with 2 or more esophageal attempts, intubations, there's 85% incidence of hypoxia. And so this is diagnosed and detected esophageal intubation. The consequences of undetected esophageal intubation are disastrous. Okay, and therefore we must always make sure we are confirming endotracheal tube placement with a capnograph. And I don't know how many units are using capnography, but in our unit it is mandatory. That is a portable capnograph, and everyone gets capnography for intubation, tracheostomy, or whatever the case may be. The skills, this may be due to differing skills. So we compared 2 ICUs in Mumbai. Our ICU was an anesthesia-based ICU. Hinduja Hospital was a physician-run ICU. And the incidence of complications seemed to be a little higher in the physician-run ICU. For example, prolonged intubation 3% versus 17%, esophageal intubation 4 versus 1, desaturation 24 versus 10. We had 1 cardiac arrest, they had none. So anyway, so again, maybe it is something to do with the skill of the person which is responsible for complications during intubation. And these few studies summarized over here suggest that intubation for respiratory failure and shock were independent risk factors for complications. So something to do with to do many factors. These are patient-related factors, and you by and large can't do too much about them, right? You can give, and because of all these things, they don't respond well to pre-oxygenation. Here you've got things where you can change. This is a stressful situation. No senior doctors around at night. Junior-most people doing the most difficult intubations. No help. They take multiple attempts. When the tube doesn't go in, it goes in the esophagus. More attempts, more chances of hypoxia. And it just goes on and on. And then the patient is not being oxygenated during the intubation attempts, and then they all develop hypoxia. And then they get bradycardia, they get cardiac arrest, other disastrous sort of complications. These are the absolutely modifiable factors, and we'll see in the next few, later on in the slide talk, how we can try and improve these sorts of factors. So one of the very important factors was that you cannot get the PO2 up with pre-oxygenation. So these investigators from France had a unique sort of novel strategy they tried out. They gave non-invasive ventilation using PEEP and pressure support prior to intubation instead of simple bag valve mask. And what they found is that oxygenation improved much better after non-invasive ventilation than after standard pre-oxygenation. And they found that the incidence of severe hypoxemia dropped dramatically, 46% to 7%, and this became sort of a better sort of thing. Many patients are hypotensive, and we use drugs to try and prevent hypotension, and the drugs that we use for intubation, whether you use thiopentone, you use midazolam, whether you use Please don't use propofol, but some people do. It can cause hypotension. So in Europe, they were comparing etomidate, which is a cardiostable agent, versus ketamine for intubation. And they found that both were equivalent. And maybe you could use ketamine as an induction agent for intubation. We all are told we should assess the airway. There are lots of tests, and the literature is full of tests for airways, assessment, and so on. But when we looked at our own practice, when we audited our intubation some time ago, there were 86 patients who had an airway set was possible. Otherwise, they didn't have cardiac arrest, they didn't require immediate intubation. You had 5 minutes to examine the patient and see how the airway was. 37% had a 40% a prior history of intubation, so they had previously operated. So you could went through the notes, you would know whether the intubation was easy or difficult or whatever the case may be. History prior to intubation was taken in 0 patients. Physical assessment was done in only 38 patients and not done in 62%. So we are not very good at following what's there in the books. We are not very good at following protocol, and we don't assess the airway very well. Even if we assess the airway, someone who's obviously difficult to intubate, you're still going to get complications because the airway is difficult. And what is really more important is that you should have some strategy to deal with a difficult airway rather than just simply assessing the airway. And this study found, so in the first phase, they did standard sort of intubation, and in the second phase they implemented the intubation bundle. And this intubation bundle consists of 10 elements. The first was pre-intubation, presence of 2 operators, preferably 1 experienced, fluid loading to prevent hypotension except if the patient had pulmonary edema, prepare sedation, pre-oxygen for 3 minutes with non-invasive ventilation, especially if the patient had respiratory failure. Okay. Rapid sequence intubation using etomidate or ketamine combined with succinylcholine in the absence of contraindication for succinylcholine. Okay. Selix maneuver to prevent aspiration, that's cricoid pressure. Confirmed tube placement by capnography. Noradrenaline if the BP falls. Immediate start long-term sedation, and then initiate protective lung ventilation. These were the 10 points of the intubation bundle. And when they used the intubation bundle, they found that the incidence of severe hypoxia dropped down dramatically from 25% to 10%, collapse from 25% and above to almost 15%, and cardiac arrest and death also to a very low figure, but because these number was small, it was not significant. And the incidence of technical complications also reduced. So essentially what it shows that life-threatening complications and other complications decreased when you intubated according to the intubation bundle. So in summary, I would say that intubation in the ICU is an airway emergency in itself. Unlike in the OT, you cannot awaken patients or postpone the case or delay the sort of intubation. You should consider non-invasive ventilation or a planned tracheostomy when a difficult airway is suspected. We should be familiar with rescue airway techniques, but most importantly, you should have a pre-planned approach. And adherence to the intubation bundle may reduce the incidence of complications during intubation in critically ill patients. Thank you.